Welcome everyone. In this lecture, we will explore the physiological properties of skeletal muscle and the major disorders associated with them. We will begin with the basic structure of muscle fibers, including the neuromuscular junction, T-tubules, and sarcoplasmic reticulum, which work together to generate the muscle contraction. Next, we will understand the five key properties of skeletal muscle: excitability, conductivity, contractility, extensibility, and elasticity. We will also connect these concepts clinically by discussing important disorders such as myasthenia gravis and muscular dystrophies. By the end of this session, you will be able to think and link the molecular muscle physiology with the real clinical diagnosis and exam based concepts. So, let's begin. Let's begin with a clinical case. Meet patient Priya K, a 28-year-old school teacher from Pune. She presents with drooping eyelids that has been progressively worsening over past 6 months. She also reports double vision, especially in the evening, along with difficulty chewing and swallowing. Now notice the most important clinical clue. Her muscle strength improves at rest. This pattern strongly suggests a neuromuscular transmission disorder rather than primary muscle damage. The ocular muscles, especially the eyelid muscles, are commonly the first affected because they fatigue very quickly. This presentation is highly characteristic of myasthenia gravis, an autoimmune disorder affecting the neuromuscular junction. In this condition, antibodies attack acetylcholine receptors, reducing the signal transmission from nerve to muscle. As a result, muscles weaken with repeated activity but temporarily recover with rest. This classic fatigable weakness is the key diagnostic feature. The mechanism of weakness, neuromuscular blockade. Now let's understand the actual mechanism behind muscle weakness in myasthenia gravis. On the left side, we see a normal neuromuscular junction. Here, acetylcholine, also called ACH, is released from the motor neuron and successfully binds to acetylcholine receptors on the muscle memory. This allows electrical transmission to occur normally, leading to muscle contraction. But now look at the right side. In myasthenia gravis, autoantibodies attack and block these acetylcholine receptors at the neuromuscular junction. As a result, even though acetylcholine is released normally, the signal cannot effectively reach the muscle fiber. So the problem is not with the nerve and not with the muscle itself. The real defect is failure of transmission at the neuromuscular junction. This is why patients develop fatigable muscle weakness. With repeated activity, available receptors become overwhelmed and muscle strength progressively declines. After rest, acetylcholine stores recover temporarily, improving the strength. That's why the symptoms worsen during the day and improve after rest. Now, here's an important clinical poll. The skeletal muscle fibers themselves remain structurally normal. Only communication between nerve and the muscle is impaired. This is a very important board style concept. Now, notice the exam angle. Relapses or worsening symptoms can be triggered by exercise, infection, stress, or pregnancy because these conditions increase the neuromuscular demand. Clinically, patients often present with ptosis, diplopia, difficulty swallowing, and generalized weakness. And since the ocular muscles fatigue rapidly, eye symptoms are usually the earliest signs. Myasthenia gravis is an autoimmune neuromuscular transmission disorder where the antibodies block acetylcholine receptors, causing the weakness without primary muscle damage. Now, let's see how doctors confirm myasthenia gravis using the Tensilon Test. Step 1. Under normal conditions, the enzyme acetylcholinesterase or ACHE rapidly breaks down the acetylcholine at the neuromuscular junction. This limits how acetylcholine can stimulate the muscle. This limits. So, in myasthenia gravis, many acetylcholine receptors are blocked by the antibodies. So, the signal becomes weak. Now comes the key intervention, step 2. The drug edrophonium, also called the Tensilon, is given. This drug temporarily inhibits the acetylcholinesterase As a result, acetylcholine is no longer broken down quickly. Step 3. Acetylcholine accumulates inside the neuromuscular junction. The increased availability of the acetylcholine helps overcome the blocked receptors, allowing better neuromuscular transmission. Because of this, muscle strength temporarily improves. That is why a positive Tensilon test strongly supports the diagnosis of the myasthenia gravis. In Priya's case, the test was positive and EMG also showed fatigable muscle response. Now look at the interactive challenge box. Which physiological property is being exploited here? The answer is excitability. By increasing the acetylcholine at the neuromuscular junction, the drug improves stimulus response coupling and enhances muscle activation. This is an important exam concept. Edrophonium is a shock-acting acetylcholinesterase inhibitor that temporarily improves the muscle weakness in myasthenia gravis. So the final takeaway is more acetylcholine means better receptor activation, better signal transmission, and temporary improvement in the muscle strength. High yield corrections myth versus the reality. Now let's clear up some very important high yield misconceptions often asked in exams. First, mechanics. A common myth says that extensibility and elasticity are the same thing. But that is incorrect. Extensibility means the muscle can stretch. Elasticity means the muscle can recoil and return back to its original shape. Stretch versus the recoil. Remember the difference clearly. Next, pathology. Another myth is that myasthenia gravis damages the muscle tissue itself. In reality, the muscle fibers are completely normal. The actual problem is failure of signal transmission at the neuromuscular junction. Now let's move to the muscular dystrophies. Students often confuse Duchenne muscular dystrophy and the myotonic dystrophy, but clinically they are very different. Duchenne muscular dystrophy usually affects young boys below 5 years and weakness starts in the lower limbs. Myotonic dystrophy commonly affects the adults with facial and tongue muscles involved early. Finally, the bone disease myths. Many think of osteoporosis and Paget's disease are both generalized bone loss disorders, but the reality is different. Osteoporosis is systemic, meaning all the bones are affected due to the reduced bone mineral density. Paget's disease is localized, affecting only specific bones, which becomes enlarged, misshapen, and painful. These differences are extremely important for USMLE, NEET PG, and Viva examinations. So always focus on concepts, not just the memorization. The five physiological properties of the skeletal muscle. Now let's understand the five fundamental ones. These are the core characteristics shared by all the muscle cells. First, excitability. This is the electrical property of the muscle. It means the muscle can respond to a stimulus from a motor neuron or hormone. Without excitability, muscles cannot receive the signals. Second, conductivity. Once the signal is generated, it must travel across the sarcolemma and the T tubules. This propagation of the action potential is called conductivity. In skeletal muscle, the conduction velocity is around 3 to 5 meters per second. Third, contractility. This is the ability of the muscle to shorten forcefully and generate the movement. Remember an important rule. Muscles can only pull, they never push. Fourth, extensibility. This is the passive ability of the muscle to stretch without damage. For example, when one muscle contracts, its opposing muscle must stretch. Finally, elasticity. Elasticity allows the muscle to recoil and return back to its original resting length after being stretched or contracted. Together, these five properties maintain the normal muscle function and the movement. And clinically, failure of even one property can produce important muscular disorders. So remember the sequence clearly: excitability, conductivity, contractility, extensibility, and elasticity. These are the five fundamental properties of the skeletal muscle physiology. Excitability, the electrical baseline. Now let's focus on the first physiological property of the muscle, excitability. So, it is the ability of a muscle fiber to respond to an electrical stimulus and generate an action potential. This graph shows how the skeletal muscle action potential over time. At rest, the resting membrane potential is around minus 90 millivolts. When a stimulus reaches the threshold, also called the firing level, a rapid depolarization occurs due to the sodium influx into the cell. The membrane potential rises sharply, reaching a peak amplitude of about 120 millivolts. Next comes the repolarization, mainly caused by potassium efflux. The entire action potential lasts approximately for 2 to 4 milliseconds. After this, the muscle enters a refractory period lasting about 1 to 3 milliseconds, during which another action potential cannot easily be generated. Now, look at the side data panel. The action and the conduction velocity in the skeletal muscle is around 3 to 5 meters per second. Chronics, which represents the muscle excitability, ranges from 0.25 to 1 millisecond. And here is the golden rule. Mechanical contraction begins only when the electrical activity is about to end. In simple words, electrical events happen first and muscle contraction follows afterward. This timing is extremely important in muscle physiology and frequently tested in exam. Contractility. Isometric versus the isotonic mechanics. Now let's move to another important muscle property, contractility. Contractility is the ability of the muscle to generate force and produce movement. There are two major types of muscle contraction, isometric and isotonic. First, isometric contraction. In isometric contraction, the muscle generates tension, but the muscle length does not change. Since there is no movement, external work is not performed. Most of the energy produced is released as heat. A classic example is pushing against a wall or maintaining the posture. Now, let's look at the isotonic contraction. In isotonic contraction, the muscle shortens while lifting or moving an object. Here, the muscle length decreases while the tension remains relatively constant. Because movement occurs, external work is performed. Examples include walking, lifting weights, or climbing stairs. Now compare both types in the table below. In isometric contraction, muscle length stays the same, tension increases, and no external work is done. In isotonic contraction, muscle shortens and tension stays relatively stable. Also, the external work occurs. Finally, notice the clinical note. Fast twitch muscle fibers contract very rapidly, with twitch duration around 7.5 milliseconds. Slow twitch fibers contract more slowly, with twitch duration around 100 milliseconds. Understanding these contraction patterns is essential for physiology, sports medicine, and clinical neuromuscular disorders. Contractility, the six force multipliers. Now let's understand the six major factors that increase muscle force contraction and the muscle force generation. These are called the force multipliers of contractility. Number 1, stimulus strength. As the stimulus intensity increases, more motor units are recruited. More recruited muscle fiber means greater force production. Number 2, stimulus frequency. Muscle force is directly proportional to stimulus frequency. Rapid repetition of stimulation can produce summation and even tetanus, leading to stronger contraction. Number 3, initial muscle length. This follows the length tension relationship, similar to Starling's law. An optimal initial length creates the best overlap between actin and myosin, producing maximum force. Number 4, load parameters. Preload increases the muscle force, while excessive afterload decreases the effective contraction. This principle is important in both skeletal and cardiac muscle physiology. Number 5, temperature. Moderate increases in temperature improve the muscle performance and contractility. However, temperatures above 45 degrees Celsius can denature proteins and damage the muscle tissue. Finally, muscle fiber type. Fast twitch fibers generate greater force and stronger contraction compared to slow twitch fibers. That is why sprinters rely heavily on the fast muscle fibers. So remember this 6 force multipliers clearly: stimulus strength, stimulus frequency, initial length, load, temperature, and muscle fiber type. Together, they determine how powerfully a muscle can contract. Structural integrity, extensibility, and elasticity. Now let's understand two important structural properties of muscle: extensibility and elasticity. First, extensibility. It is the passive ability of a muscle to stretch without damage. No energy is required for this process. This property is very important in antagonistic muscle pairing. For example, when the biceps contracts, the triceps must stretch. Without extensibility, smooth coordinated movement would not be possible. Now look at the pathology link. Loss of extensibility can lead to spasticity, where muscle becomes stiff and resists stretching. Next is elasticity. It is the ability of the muscle to recoil and return back to its original resting length after being stretched. This recoil is mainly produced by the parallel elastic components within the muscle. In simple words, extensibility allows the stretch, while elasticity allows recovery. Now remember this high yield formula at the bottom. Active tension equals total tension minus the passive tension. This concept is very important when analyzing the muscle mechanics and force generation. So the key takeaway is simple. Extensibility means stretch. Elasticity means recoil. Both are the essential for normal posture, movement, and muscle stability. Systemic breakdown, bone and joint pathologies. Now let's connect muscle physiology with important bone and joint disorders. First, osteoporosis. Osteoporosis is a systemic disease, meaning it affects all the bones in the body. There is a reduction in bone mineral density, making muscles weak and fragile. Major mechanisms include inadequate peak bone mass, excessive bone reabsorption, and inadequate bone formation. This significantly increases the fracture risk, especially in elderly individuals. Next is Paget's disease. Unlike osteoporosis, Paget's disease is localized. It usually affects only one or a few bones. This is an excessive breakdown followed by the abnormal bone formation. As a result, the bones become enlarged, misshapen, and painful. Now let's look at the arthritis. It refers to the inflammatory joint disease, and there are 100 different types. Inflamed joints commonly present with stiffness, warmth, pain, and swelling. It is especially common in elderly women. Management often includes NSAIDs, physiotherapy, and lifestyle modification. So remember the key distinction. Osteoporosis is systemic bone loss. Paget's disease is localized abnormal bone remodeling, and arthritis involves the inflammation of joints. Initially, these are highly important clinical correlations in musculoskeletal physiology and pathology. Now let's look at what happens when muscle excitability becomes excessive, a condition called tetany. The root cause is usually severe hypocalcemia, meaning very low calcium levels in the blood. Normally, calcium helps stabilize nerve and muscle membranes, but when the calcium levels drop, the threshold for action potential also drops. As a result, nerve begins firing spontaneously and repeatedly, causing uncontrolled muscle contractions. This is basically excitability running out of control. Clinically, patients develop painful muscle spasms, especially in the hands and the feet, called carpopedal spasm. Severe cases can even cause laryngeal spasm, which may interfere with breathing and become life threatening. The key exam point is this: tetany is not due to structural muscle damage. It is an electrical instability problem caused by altered membrane excitability. So remember, low calcium increases excitability, leading to involuntary spasm and sustained contractions. Here is a rapid, high yield comparison of four major neuromuscular disorders commonly asked in exams. First, Duchenne muscular Dystrophy or DMD. It is an X-linked disorder affecting young boys, usually before 5 years of age. Weakness starts in the lower limbs and progresses upward rapidly, often leading to respiratory failure in adolescents. Next is Facioscapulohumeral dystrophy, that is FSH. This affects both sexes and usually begins during adolescence. The weakness mainly involves the face and the shoulder muscles. Progression is slow and many patients have a normal lifespan. Third is myotonic dystrophy. This presents in adult life and commonly affects the face and the tongue first. It is progressive, has no remission, and also involves systemic organs like heart and the endocrine system. Finally, myasthenia gravis. Unlike muscular dystrophies, this is an autoimmune neuromuscular junction disorder. It commonly affects women between 20 to 40 years. The earliest muscles involved are usually the eyelids and the extraocular muscles, causing ptosis and diplopia. The most important concept in myasthenia gravis, the muscle itself is normal. The antibodies only block acetylcholine receptors at the neuromuscular junction. This table is extremely useful for differentiating disorders quickly in competitive exams and viva discussions. Now let's connect everything together. This slide shows how normal muscle physiology transforms into disease when one specific property fails. First, normal excitability and conductivity allow proper electrical signal transmission, but when signaling becomes blocked or excessively active, pathologies develop. Blocked transmission leads to myasthenia gravis, while hyperactive signaling causes tetany. Second, normal contractility and structural integrity maintain the muscle strength and stability. When these fail, the muscle undergoes wasting and structural breakdown, resulting in muscular dystrophies like Duchenne, FSH, and myotonic dystrophy. Third, normal extensibility allows muscles to stretch passively during the movement. Loss of this property causes rigidity and spasticity where muscles resist passive movement. So, the major takeaway is simple. Pathology is basically normal physiology pushed beyond its normal limits. If you understand the normal physiological property, you can predict the disease, its symptoms, and even its clinical presentation. Now let's end everything with a high yield clinical MCQ challenge. A 23-year-old man cannot release his handshake properly. This delayed relaxation is called myotonia. He also has involvement of the tongue and the facial muscles with adult onset and a positive family history. These clues strongly point towards myotonic dystrophy. Now the question is, what additional feature is commonly associated with disease? The correct answer is cataracts, gonadal atrophy, cardiomyopathy, and glucose intolerance. Why? Because myotonic dystrophy is not just a muscle disease, it is a systemic disorder affecting multiple organs. Notice how the incorrect options represent other diseases. This is exactly how integrated physiology and pathology develop and helps us solve the exam questions quickly and accurately. Thank you everyone for listening and learning with me today. From normal skeletal muscle physiology to major neuromuscular disorders, we explored how tiny physiological changes can lead to important clinical diseases. Remember, if you understand the normal function, understanding pathology becomes easier. I hope this session helped simplify complex concepts and made them more clinically relatable and exam oriented. Keep learning, keep connecting physiology with real clinical practice, and most importantly, stay curious. Thank you.